Assalamu alaikum warahmatullahi wabarakatuh. Good day everyone. So post-treatment endodontic pain is a frequent complication after root canal treatment and often peaks within 24 hours and commonly is attributed to apical extrusion of the brain inflammation. Preoperative pain and sensitivity to percussion is a reliable sign of inflamed apical tissues that have been proved to predispose patients to severe post-operative pain. So occlusal reduction has been proposed long time ago as a strategy to reduce this pain, but all previous studies have reported conflicting results. Therefore, this trial aimed to assess whether occlusal reduction significantly decreases post-treatment pain in mandibular posterior teeth with symptomatic irreversible pulpitis and sensitivity to percussion. It's a prospective two-arm parallel group randomized control trial done in a university setting in Cairo, Egypt by Dr. Ahmed along with Dr. Bayoumi. It was published in 2020 at the International Odontic Journal. It included 308 patients that were systematically healthy adults, age range between 18 to 65, with moderate to severe pain, and a diagnosis of symptomatic irreversible pulpitis in mandibular posterior teeth. Patients were randomly assigned by block randomization with allocation concealment using sealed envelopes. The endodontic treatment was done in 2 visits with no intracanal medicament placement, using 2.5 sodium hypochlorite irrigation and a lateral condensation obturation. The temporary restorations adjusted to avoid the occlusal interferences. For the outcome measures, the primary was the pain intensity measured on a 0 to 10 numerical rating scale at 6, 12, 24, and 48 hours post-instrumentation, 6 and 12 post-obturation. The secondary outcome measure was the analgesic intake. In this study, each patient was first given a sham capsule, which is a placebo. It's a capsule with no active drug filled with powdered milk. And if the pain did not subside, they were then instructed to contact the operator, who would prescribe an action analgesic, which is ibuprofen 400 milligrams. For the results, the pain intensity was significantly lower in the occlusal reduction group at 12 and 24 hours post-instrumentation compared to the control group. Both groups showed a gradual and significant reduction in pain over time at all post-instrumentation and post-obturation intervals compared to the pre-operative levels. For the moderate to severe pain at the 12 hours post-instrumentation, it was approximately 40% lower probability of experiencing significant pain in the occlusal reduction group when compared to the control group. As for the analgesics intake, almost a third of the 308 patients took the sham capsule, and of those, 18% of them ended up taking ibuprofen 400 milligrams, the real analgesic, with no statistically significant difference between the groups. This indicates that the majority of the patients did not progress to real analgesics, meaning that the pain was tolerable or thought to be relieved by the sham capsule in many cases. This study did not report the exact time in hours when the ibuprofen was taken, but it was available on demand anytime after the sham capsule was taken. And the reasons why they did not use intracanal medicament was because they wanted to eliminate any confounding variables with the use of intracanal medicament, which has the antimicrobial, anti-inflammatory effects that can reduce the pain on their own. And they also wanted to stay consistent with some landmark studies, such as the classic Rosenberg in 1998, where they did not use any intracanal medicament. And they also wanted to measure the natural course of pain by leaving the canals dry and sealed with cotton pellets and temporary restorations. Finally, my critique on this paper is that although the study's 2-visit design without intracanal medicament improves its internal validity by trying to eliminate the confounding variables and wanted to have some control over these variables, so any differences in the pain levels can be confidently attributed to the occlusal reduction rather than the medicaments or other pain modifying factors. It does not fully reflect the typical clinical practice in many clinics, including mine, where the intracanal medicament with the use of calcium hydroxide is routinely placed between visits to control for the bacterial load and reduce inflammation and post-operative pain, which in my opinion this raises an ethical concerns, While the study was ethically approved and the patients were closely monitored, this protocol may not align with the principle of providing the best possible care. Another significant ethical concern, in my opinion, in this study where they used the sham capsule, the placebo, as the first line analgesics when the patients reported pain, although the protocol allowed the patients to access the real analgesics, the ibuprofen, if the pain persisted. The initial placebo step meant that the patients experiencing genuine pain were knowingly giving a non-therapeutic intervention, which could potentially delay the effective pain relief. This raises questions about whether the study fully followed the principle of beneficence, which obligates us as clinicians to minimize suffering when a proven treatment is available. In our routine practice, patients persisting with moderate to severe pain are offered analgesia, not a placebo, while the authors justified that this design is a way to differentiate true analgesics need from preventive or fear-based intake. This decision to expose patients to continued pain, even if it was for a short time, I don't believe that this is ethically acceptable for all practitioners to do for the sake of research, particularly in studies involving acute and potentially severe pain. Thank you so much for listening. Hope you have a good day. Bye.